the vaccine will be cold when you remove it from the fridge, but 12 hours of time it would not have been kept under the, in cold chain. So things are changing. People are becoming more responsible, more accountable, and more aware of how things should be done. So there will be an issue with cold chain, especially if it is a vaccine requiring -80-degree storage. It is not practical in India. The other vaccines which are likely to be coming in are vaccines which can be stored between 2 and 8. So I think the Indian government will be sensible in picking up which vaccine this will be practical and applicable in the Indian scenario. So that is an important thing to keep in mind.
Thank you so much, sir. I think we can wrap it up now. Thanks, Dr. Srinivasan, sir, and Dr. Ram Subramaniam, sir, for the excellent talk. Thank you.
Thank you.
Thank you. Thank you, Mani.
Thank you, sirs, for a great discussion. We now proceed to the last session in Hall B. This is on diabetes clinics. This session is going to be chaired by Professor AKD, sir, and Dr. Suresh Prabhu. Dr. AKD, sir, is a consultant endocrinologist and physician from Pondicherry. He was a former professor and HOD of Department of Endocrinology in JIPMER and also in PEMS. He was a past national president of API and also RSSDI. He has numerous publications, more than 150 publications in both national and international journals. And I'm privileged to introduce my teacher, Dr. AKD, sir. The next chairperson is Dr. R. Suresh Prabhu. He's a consultant endocrinologist in Ganga Hospital, Coimbatore. He is a member of ESTN. He has multiple publications in national and international journals. I request the chairperson to introduce the first speaker.
Dear friends, it is a great pleasure to invite the esteemed 4 speakers on my own behalf, on behalf of my very esteemed colleague, Dr. Suresh Prabhu. So I'll take up the first speaker we have discussed. Now, dear friends, we have got a very information-packed, the cream de la cream speakers packed session. And I have been informed that each talk will be about 20 minutes and 10 minutes will be for the discussion. You may kindly put your questions in the chat box for the discussion. Dear friends, the first speaker, I'm honored to invite Dr. Mark W.J. Strachan. He is MD, FRCP Edinburgh. He is currently the consultant in diabetes, endocrinology, and honorary professor at the Edinburgh Centre for Endocrinology and Diabetes, University of Edinburgh, Scotland. He has been the editor of the phenomenal book, Davidson Principle and Practice of Medicine, very popular in our country. He had been the Diabetes UK, the Lawrence Lecturer of the King's College fame, former Secretary of the Royal College of Physicians of Edinburgh. He has many publications. Number 1 is the 23rd edition of the Principle and Practice of Medicine and 125 publications in the peer-reviewed journal. Dear friends, we are very happy to welcome Dr. Mark, and he's going to speak to us on a topic which I will just introduce 2 sentences. It's the most important contemporary challenge in our country, with 32% above prevalence, number 1 cause for the cirrhosis going to become, or transplant, or for the coronary disease, or for the any part of metabolic syndrome. Over to Dr. Strachan to give his lecture on this NFLD, the screening and management in type 2 diabetes, screening and management. Dr. Strachan, all is yours.
Thank you very much, Dr. Das. I hope you can hear me, and I'm going to try and just share my slides now, and hope you can all see them okay. Can you see my slides?
Yes, yes.
Excellent.
Yeah, it is visible.
Great. Well, it's a real pleasure to be able to speak with you today. I'm only sorry I can't be there in person. As part of my role as one of the editors of Davidson's, I had the real pleasure of visiting India 2 years ago, and I spent a week in India traveling around having the most amazing time. So I do hope to be back soon. A couple of things I just want to point out. It's absolutely pouring with rain here in Edinburgh at the moment. So if you hear a funny noise in the background, it's the rain battering against my window. And the other thing to say is sometimes something a bit strange happens with my computer, and it freezes after about 30 minutes. So if I do freeze, don't worry, I will come back. It's just some quirk of my computer. So as Dr. Das said, I'm going to be speaking to you about non-alcoholic fatty liver disease in type 2 diabetes. As you know, in terms of worldwide causes of liver disease, there are three major groupings. There is non-alcoholic fatty liver disease, or NAFLD, viral hepatitis, and alcohol-related liver disease. And as Dr. Das rightly said, NAFLD is now, in many societies, the most common cause of end-stage liver disease. And of course, that is predominantly obesity-related liver disease. Of course, people with type 2 diabetes can get any form of liver disease. They're not, it's important to remember that not all liver disease in somebody with type 2 diabetes is NAFLD. People with type 2 diabetes, of course, can get hepatitis B and hepatitis C, and can get alcoholic liver disease as well. But NAFLD is very common. If you look at fatty liver steatosis, ultrasound studies have shown that up to 70% of people with type 2 diabetes have steatosis. And that's probably 2 to 3 times higher than in non-diabetic individuals. Not only is steatosis more common in people with type 2 diabetes, the progression of that steatosis to advanced liver disease, cirrhosis, and hepatocellular carcinoma is also more common. Overall, in people with diabetes, the risk of progression over a 5 to 20 year period sits somewhere between 1 and 10%. The literature is very variable on this because it's very heterogeneous studies that have been reported. But overall, the risk of progression is somewhere between 3 and 8 times more common in people with type 2 diabetes. So I've mentioned steatosis, fat accumulation in the liver. So we know basically that as people gain weight, they initially lay down that adipose in visceral tissues, in the omentum, and in other tissue around the central abdomen. But then as obesity increases, it starts to be deposited in other ectopic sites, and the liver is foremost of those. In some individuals with steatosis, that will progress to what we call NASH, or non-alcoholic steatohepatitis. So that is, in a sense, steatosis associated with inflammation. And in some individuals, that will in turn progress to fibrosis. And then in some, that will progress to end-stage disease with cirrhosis and or hepatocellular carcinoma. The pathogenesis of NAFLD is very complex, and we do not fully understand it. There are a whole variety of factors at play. But what we know is that people with type 2 diabetes are much more likely to have steatosis, and they are more likely to progress to these more advanced forms. As Dr. Das also said in his introduction, there is a strong association between increased mortality, particularly from cardiovascular disease, in people with NAFLD, probably about a 1.6 increased risk of cardiovascular disease in people with NAFLD. Now, throughout my talk, I'm going to be presenting some of our own data from Edinburgh, from what's called the Edinburgh Type 2 Diabetes Study. This is a prospective study that we established now about 15 years ago in Edinburgh, looking at risk factors for liver disease and, in fact, another interest of mine, cognitive impairment in type 2 diabetes. And in effect, people were invited at year 1 of the study to have an assessment of steatosis by ultrasound, and also a variety of other measures taken. And then people were followed up at 11 years to see who had developed cirrhosis and hepatocellular carcinoma. Now, in the Edinburgh Type 2 Diabetes Study, we identified 7 cases of cirrhosis or hepatocellular carcinoma at baseline, and another 39 cases during follow-up. So that means that the 10-year prevalence of cirrhosis and end-stage liver disease in our cohort is 4.3%. Now, it's an older cohort, so these were all people aged between 60 and 75 years at recruitment, and they were predominantly Caucasian, because that represents the ethnic breakup in the local region. And have developed advanced liver disease at some point over the 10-year period. The overall incidence of cirrhosis was 4.24 per 1,000 patient years, and of hepatocellular carcinoma, 1.45. And if you compare these rates to that in the general population, it backs up what I was saying at the beginning. They're much increased. So in the case of cirrhosis, our incidence is about 10 times higher than the general population, and for hepatocellular carcinoma, about 3 times higher than the general population. Now, many august international bodies recommend, therefore, that people with type 2 diabetes should be screened for NAFLD. For example, in Europe, these guidelines by EASL, EASD, and the EASO recommend screening. And there are a variety of different ways that you can screen people for NAFLD. You could measure straightforward blood liver function tests that we're all familiar with. There are various panels of biomarkers, predominantly looking at fibrosis that you can measure. You can do scans to look for steatosis, an ultrasound scan, or an MRI scan. You can calculate something called the fatty liver index, which I'll speak about in a minute, which also gives a measure of the likelihood of somebody having steatosis. And you can do scans for liver fibrosis, transient elastography, sometimes commonly a scan called a fibroscan, or MRI elastography. And you can even do a liver biopsy. So there are a whole variety of different ways that you can screen for NAFLD. Now, as you know, the World Health Organization specify a variety of different standards for what represents a good screening test. Now, in the case of NAFLD, you can certainly argue that this is an important condition because we know it leads in a proportion of individuals to end-stage liver disease, 4.3% in our cohort here in Edinburgh. Arguably, the facilities for diagnosis and treatment are available. Now, clearly that will vary in different parts of the world, the level of facilities for diagnosis and treatment are available, but broadly speaking, they are available. And there is a recognized latent or early symptomatic stage in the form of hepatic steatosis. However, if you look at the imaging modalities, mainly by MRI and liver biopsy as screening tools, these don't really meet the tests that the examination should be acceptable and cost effective. You know, the notion of screening everybody with type 2 diabetes with an MRI scan is clearly not realistic or plausible. And it would really not be ethical to do a liver biopsy on everybody with type 2 diabetes. But the blood tests certainly would meet the acceptability test, and to some extent would meet the cost test, although again, that is variable. Ultrasound as a screening test, I think, is on the edge. You could imagine clinics being set up with ultrasounds in the clinic, but again, it's probably not going to be something that is suitable for all across the world. Now, I mentioned the European guidelines. So this is the algorithm that the European guidelines recommend for screening for NAFLD. So they say that if you have metabolic risk factors, and that would include somebody with type 2 diabetes, then you should have an ultrasound and measurement of liver enzymes. Now, as I've said, ultrasound is not really a realistic screening tool for everybody with type 2 diabetes. So straight off, we've got a problem with these guidelines. But they do say that you can use a steatosis biomarker as an alternative to ultrasound. And the fatty liver index is one such biomarker. It's basically a very complicated equation, but which uses triglycerides, body mass index, gamma GT, and waist circumference to calculate an increased likelihood of having hepatic steatosis. If steatosis is present and liver blood tests are abnormal, then you should be referred into a specialist clinic. If the liver blood tests are normal, then they say you should have a fibrosis marker done and then referred in if that shows you to be at medium or high risk. And I've just given an example of one fibrosis marker, which is called FIB4, and that uses age, AST, ALT, and platelet count, again in a complicated equation to give a likelihood of fibrosis. But as I say, there's a variety of different forms of that. Now, in the Edinburgh type 2 diabetes study, we have compared the performance of some of these different fibrosis markers, and there's a big problem with them. They actually perform very poorly when you apply them to community-based screening. So most of these tests have been validated in secondary care and even tertiary care liver clinics, where obviously there is a high background prevalence of cirrhosis and advanced liver disease. In the community, the pre-test probability of somebody with type 2 diabetes having cirrhosis and or hepatocellular carcinoma is obviously very low. And so that means that these tests perform much less well. If you take, for example, the NAFLD fibrosis score with this cut point here, if you apply that to our population in the Edinburgh type 2 diabetes study, we found that it was very good when it came to false negatives. So by that, I mean the test was negative in somebody who actually did go on and develop cirrhosis or end-stage liver disease. Effectively, it only missed 3 cases of NAFLD, of advanced liver disease. But the problem was with this test was that the false positive level was enormous. So 769 people had a positive test, positive score on this, but actually didn't go on and develop advanced liver disease. So clearly that's useless as a test. And as a broad principle, if you reduce the number of false positives in the test, you then increase the number of false negatives. So if you take a different cutoff for the NAFLD fibrosis score, a lower cutoff, you reduce the false positive rate very substantially, but you then increase the false negative rate so that in this situation with this cutoff, you miss 55% of people who are going to go on and develop cirrhosis. However, you could argue, you could take the viewpoint, well, at least if we pick up some people who are going to develop cirrhosis, then that's better than nothing. And as long as the test has got a low false positive rate, we're not going to be wasting health resources by referring in people, large numbers of people who are never going to get disease, and we're not going to be causing unnecessary worry. So if you take that viewpoint, then you might use the FIB4 test with this high cutoff, or the ELF test, which, although they missed about 60% of cases of cirrhosis, on the other hand, they picked up 40% of them, and they had very low false positive rates. Now, we've looked in the Edinburgh type 2 diabetes study to see if we could improve the performance of these these fibrosis tests by adding in other biomarkers. And we looked at a variety of other diabetes variables that were associated with an increased risk of developing advanced liver disease. And when you plug these into complicated statistics models, the ones that perform best are gamma GT and hyaluronic acid. Hyaluronic acid is a blood measure of fibrosis. So for example, if you take FIB4 with a cutoff of 1.3, so it's got a false positive rate of 40% and a relatively low false negative rate of 17%. And if you add in hyaluronic acid, you reduce the false positive rate by half, but you don't get too much of an increase in the false negative rate. But you would, if you employ FIB4 and hyaluronic acid, you're still going to be referring a quarter of all, or a fifth of all your patients with type 2 diabetes for a specialist assessment in individuals who are never going to get advanced liver disease. Just to show you by way of an example or comparison, if you just take liver function tests, abnormal liver function tests, they perform actually similarly to FIB4 and hyaluronic acid. So a false positive rate of 27% and a false negative rate of 25%. So if you've got abnormal liver function tests, any abnormal LFT, then you will identify 3/4 of cases of people who are going to go on and get cirrhosis, but you will identify, you will pick up 27% of everybody will have at least one abnormal liver function test and will not go on and get cirrhosis. If you combine abnormal liver function tests with the fibrosis markers, then you reduce that false positive rate down to 7.6%, and the false negative rate is just under 50%. The European algorithm with ultrasound measures doesn't perform brilliantly in terms of false positives, but has got low false negative rates. So if you go back to the WHO screening test, the currently available markers that we have don't perform brilliantly. But why should we screen for NAFLD? Well, in theory, if you identify somebody as having steatosis, because we know that that is associated with increased cardiovascular mortality, then you could reduce cardiovascular mortality, in theory, and you may be able to give them an intervention that prevents their progression to more advanced liver disease. If you identify somebody as having inflammation or fibrosis in the liver, then screening in these individuals can predict whether they're going to have cirrhosis, and in particular whether they've got varices, which you can obviously ban or give other medical treatments for to reduce the risk of future bleeding. And you can screen them for hepatocellular carcinoma, which may in theory allow earlier treatment. So in theory, there are good reasons why you may want to detect NAFLD. However, in our study, we didn't find that ultrasound detected steatosis was associated with increased mortality or increased cardiovascular death. In fact, you can see that actually, if anything, the death rates were slightly higher in people who didn't have steatosis compared with steatosis over 10 years. Now, you may say, well, hang on, that doesn't make sense, because you said right back at the beginning that NAFLD is associated with higher cardiovascular mortality. And actually, I believe that it is, but it's more that ultrasound is not a brilliant way of picking up steatosis. So although I said that ultrasound identifies 70% of people with type 2 diabetes as having steatosis, that doesn't mean that the other 30% don't have steatosis. Some of them actually do, but it's just below the resolution of the ultrasound machine. It's just that ultrasound is not a perfect test for picking up steatosis, but it's the best that we have. And that's just the Kaplan-Meier curve, just showing that there's not really much benefit in detecting steatosis on an ultrasound from a cardiovascular point of view. So, what about the aspect of treatment, about giving treatments that can reduce the risk of progression? Well, we know that if you lose a large amount of weight, either by lifestyle or with bariatric surgery, that will reduce the amount of fat in the liver. We know that drugs like the SGLT2 inhibitors and GLP-1 agonists and pioglitazone reduce the amount of liver fat. I've put pioglitazone in brackets just because obviously it's not used quite as much as it used to be in the past because of the safety concerns. But what we don't know, though, particularly with the drugs, is whether this reduction in steatosis is ultimately associated with a reduced impact on liver disease in the future. We believe it is, but it's just that the studies haven't been long enough to prove that yet. But of course, the other issue is that, of course, we're very often using these drugs in people with type 2 diabetes anyway. And so knowing that somebody's got steatosis isn't necessarily going to change the treatment or the treatment advice that we're going to be giving people. So then you then start thinking, well, why do I need to bother identifying that that person has got steatosis in the first place by ultrasound? Because it's not necessarily going to reduce their risk of getting advanced liver disease, because I may be giving them treatments, the treatments that might do that anyway. And to say that our data is that actually it doesn't even predict increased mortality. So I've given this one an amber about the acceptable treatment for patients with disease. So in conclusion, I'm afraid this is a bit negative, really. The current biomarkers that we have actually, although they can identify people with steatosis and NAFLD, they perform very poorly in predicting who will get advanced later liver disease down the line. Measuring liver function tests and a fibrosis marker if liver function tests are abnormal will identify, in our experience, about half of those who will go on and develop advanced liver disease with a relatively low false positive level. If you want, though, a test that identifies everybody who's going to develop advanced liver disease, well, you will have to accept a very high false positive level and a very high referral rate to specialist care for individuals who will never go on and get advanced liver disease. That is until we get a better biomarker. And as I say, it is arguable that knowing an individual with type 2 diabetes has steatosis or not is useful, because most people with type 2 diabetes have steatosis anyway. It may not be associated with increased cardiovascular mortality if you pick it up with an ultrasound scan, because it's not a perfect test. And we're already giving the interventions that reduce liver fat. And that was all I was going to say. Thank you very much indeed.
Thank you, Dr. Yes, that's it there. Okay, sir, you can go ahead, sir.
Yeah,
sir, your mic is on mute.
No, I'm not on mute.
Yeah, Dr. Das, Dr. Eke.
Dr. Das, sorry, my apologies. You're muted.
Sir, your mic is on mute, sir. Das, sir. Dr. Eke Das, your mic is on mute, sir. Yes, now it is on.
I can't hear you, Dr. Das.
Dr. Das, Dr. Eke Das, sir, your mic is on mute, sir. We are unable to hear, sir. We are unable to hear.
See, is it audible? Am I audible now?
That's it. We can hear you now.
Now it is on. Now
yeah. So now I just wanted to tell you that I like the way you developed the whole story. Your story about the prevalence, story about the 3 most important liver disease, and also story that is the assurance that anyway steatosis is there. We need not be too perturbed about the impending coronary disease.
So now once again, I think it got into mute, sir.
Dr. Das, I'm sorry, I can't hear you again.
Okay.
Yeah, now it is okay, sir. I think
Okay.
it is going to
I
mute.
must tell you that what is most important is the screening must be very simple. So
Yeah.
there's a question in the chat box. What is your recommendation for the easiest screening method for UK and India, if at all you're doing a screening?
Yeah, so the easiest screening method is to measure liver function tests, because that's easy, it's widely available, and is relatively cheap. The problem...
Are you meaning the transaminases?
Yes, well, transaminases and gamma GT.
Gamma GT. How do you see the ultrasound machine is widely available, but not the one with the fibroscan?
Yes,
If
that's right.
in the physicians across the country, can the ordinary ultrasound of a grade 2 or whatever, will it pick up the cases if at all we do a screening program in the country?
No. So ultrasound will show you if you've got fat in the liver. And of course, the other thing that ultrasound will show is if there is any other pathology. So it will let you see if the liver is cirrhotic, if the spleen is enlarged, if there is a tumor there, or if the bile duct is dilated. So I don't want to be too negative about ultrasound from the point of view of its ability to detect structural liver disease in general and advanced liver disease in general. But when it comes to NAFLD, all the ultrasound can do is show you that the liver has got fat in it. You can't tell if there's inflammation there, and you cannot tell if there is fibrosis there. A fibroscan will tell you if there is fibrosis there, but that screening test, that scanner is not very widely available. And actually, it's quite a tricky scan to do in people who are overweight anyway. It's not an easy scan to do. So liver function tests are the easiest tests to do, and will pick up about half of the people who are likely to get advanced liver disease.
Great.
These are
the last question from my side is, it has been reported that the hepatogenous diabetes is almost 41% in some studies, starting with 14% to 41%. What is your gut feeling? Sorry, Sachin, for this question. Hepatogenous diabetes.
For the prevalence of NAFLD in type 2 diabetes?
Yes. No, I'm telling hepatogenous diabetes in general. Of course, NAFLD is the good portion, but also SCV, whatever the other liver disease. Hepatogenous diabetes. Do you use this term in UK?
No, I don't recognize that term. Sorry.
Okay, we'll leave that. Now, the final question is that out of the treatment that we said, metformin, you are totally ruling out metformin, vitamin E, or it is in your armamentarium, Dr. Sachin?
Yeah, so the evidence about metformin in NAFLD is not great. Metformin obviously does cause a little bit of weight loss, but the impact on steatosis is probably, well, the reality is it probably doesn't matter what treatment you have.
Okay.
It's the weight loss that is the key thing.
Fantastic. I think that's the reason for the SGLT2 and GLP2 inhibitor.
Yes, I agree as well.
Yeah. Suresh, do you have any question in the chat box?
Yes, sir. I think, do we have any recent evidence to show that we have a lot of trials are coming up? Do we have any evidence that any SGLT2 inhibitors have a role? Means any positive evidence to show that in NAFLD?
I mean, there are trials ongoing looking at this, but there are some studies that have been published. They're relatively small, that show that SGLT2s are associated with a reduction in liver fat. But what none of the trials show is that any treatment reduces the risk of cirrhosis or hepatocellular carcinoma, which of course ultimately is the key outcome. Whether you've got a bit of fat in your liver as such, arguably doesn't matter. It's asymptomatic. It's not causing you any problems. It's whether you get advanced liver disease that is the key outcome. And that's what's not been shown in these studies. But it is reasonable to presume that if you reduce steatosis, that in the future that will reduce the risk of advanced liver disease. It's just not been proven yet. But I would just reiterate that any treatment that causes you to reduce weight will, in all likelihood, have a positive impact on steatosis.
I think Suresh, brilliant question. I just close by saying that one paper published from Amrish Mittal, one of an Endocrine Society of India past president, he showed with one of the SGLT2 inhibitors a human study where he showed by ultrasound the NFL score came down, but that is just published by Dr. Amrish Mittal. I think big hand for Prashan for a great talk. Great talk. Thank you very, very much. Thank you very, very much.
Thank you. My pleasure.
That's a nice talk, sir. Thank you.
Shall I take up the next one? Then you can take up both international and the Indian speaker. Shall I do the next one? You can take up the next two speakers together.
Yes, sir. No problem. You can go ahead.
Dear friends, it's my great pleasure on my own behalf, on behalf of Suresh Prabhu, an eminent endocrinologist from the city of Coimbatore, to invite Dr. Ashu Rastogi. Dear friends, I have seen Ashu growing, and to the height that he achieved today is a rare feat today. I must tell you that below 40, the achievement that he has had is really great. MD, DM, has got a MNMS, FAC, FRCP. But what distinguishes Ashu from others is possibly his interest in research and the publication. You will see by his presentation, which I have seen many other presentations, not this one, that he has widely worked in the field of diabetes and especially diabetic foot. And no, he has got many awards. He has got the award of the Certificate of Appreciation from his own institute, travel grant, Outstanding Abstract Award from the US Endocrine Society, A.B. Gandhi Award, which is given to the best outgoing DM student for the whole country. If I tell about it, there'll be no time left for him. So therefore, today, both of us invite now Ashu Rastogi to speak to us on a very, very important topic, the foot problem in this type 2 diabetes and what we should not miss. What we should not miss. Ashu, stage is yours.
Thank you, sir. And I'm humbled by such a nice introduction by Professor A.K. Das, who is my revered teacher always, and I have learned so much from him. But I'll not waste time, and I'll just come directly to the point. And what is very close to my heart is the diabetic foot complications. And I hope that my slides are visible.
Yes, visible. Yes, visible. And
yeah.
Now.
So instead of telling the august audience here that what we should know, I will just tell you what we should not miss. And most important is what we should not miss is in the story is a gentleman, we should not miss the foot. This was the picture I took from the shores of Hague in Netherlands, where the IWGDF, which makes the foot guidelines of the world, meeting was going on, and I was also the part of it. And I was shocked to see this bronze statue, huge statue on the seashore of Hague, Netherlands, bordering England along the North Sea. And I could see a soldier who was just carrying his gun without another foot because it was amputated. So my purpose of giving this lecture is to prevent this outcome of complications. And what I would discuss in the future slides is what we should not miss whenever we see a patient of diabetes, especially if you are seeing a patient of diabetes in your clinic. It's not about glucose, it's not about other complications, but it is also about foot complications. That is important. We should not miss many features or the history pointers that is important and pertinent for a patient. Few things that we should not miss in clinical assessment, in inspection and palpation. Importantly, some investigations that are armamentarium of every physician who sees a patient of diabetes, especially the radiological evaluation. And finally, few things that we should not miss while dealing a patient of foot complications during management. Importantly is that we should always ask a patient of diabetes about a prior history of ulceration and prior history of amputation. Because remember, if a patient is having a prior history of ulceration and amputation, it begets further ulceration and amputation. If a patient is already having a prior angioplasty or vascular surgery, that suggests that he is at a very high risk of ASCVD event, and this patient needs your proper care. History of neuropathic symptoms and vascular symptoms, and most importantly, I would highlight again the presence of other diabetic complications, whether it may be renal complications or retinal complications of visual impairment. Last and most important is the duration of diabetes, because it has been noticed that as the duration of diabetes increase, the prevalence of neuropathy increase, the prevalence of vasculopathy increase, and the incidence of ulcers also significantly increase. By this slide, I just mean to say that we should not look only the wound or the affected foot. We should see the patient as a whole, and we should not miss seeing or asking the patient about other complications that might be coexisting in a patient of diabetes. And why I do say that, this is because of this largest study till date in the world, and this is from our own country. We have 7 centers all across India were invited to participate, and what we did, for more than 4,700 patients of diabetic foot, predominantly who had neuropathic ulcers, were compared with age as well as duration of match people of diabetes without foot ulcers, and they were prospectively followed over a period of around 8 years. This is just like a UKPD's kind of study, and we studied limb amputation and mortality after a incident neuropathic foot ulcer. And to a surprise, if a patient has an ulcer and he comes to your clinic, he is likely to die, and his chances of dying is around 5 times more as compared to a patient of diabetes who does not have a foot ulcer. So this is a horrible figure, and we should never forget it. And the most common cause of death these patients of foot ulcers is again ASCVD event or ACS or coronary artery disease. This was published in DRCP. Same, if you are having a patient who have a Charcot's neuroarthropathy, we again studied prospectively over a period of 5 years in a patient cohort of 260 patients of Charcot's, and we matched them with 2 times controls who were diabetic patients, who had neuropathy, who were age and duration of diabetes matched, but they were not having Charcot's. And we followed these patients, and we just wanted to see what is the prevalence of diabetic complications in patients with Charcot's. We were surprised again, if a patient is having Charcot's, he is likely to have retinopathy more, he is likely to have nephropathy also more, he is likely to have neuropathy as expected, as compared to a routine diabetes patient who does not have Charcot's. Interestingly, we again followed these patients over a period of 5 years, and we found out that the mean survival of these patients who have Charcot's is significantly less, and the odds of dying is almost 3 times as compared to a routine diabetic patient with neuropathy but without Charcot's. So always remember, foot complications are not only important for foot, but they are also important for a patient as a whole, because they are at increased risk of mortality. So whenever you see a patient of diabetes, always assess for both neuropathy as well as vasculopathy, and that should not be missed. Even at diagnosis of type 2 diabetes, you have to screen for neuropathy and vasculopathy. And if a patient is type 1 diabetes, 5 years after the diagnosis, he should be screened. And after that, at least annually, should be screened. Now, coming on to important part, I'll be covering what you should not miss is whenever the patient comes to your clinic, the time he opens the door and he walks to the patient observation chair, just observe his gait. And that time is also very important, because just by looking at the patient entering and sitting in the examination room, you can notice many things, and most importantly, by looking at the stance, the posture, the velocity of his steps, the step length, the symmetry, you can definitely know that this patient is probably having a peripheral neuropathy or autonomic neuropathy. Suppose if the patient is having high stamping gait, it suggests neuropathy. If he has a slipper which slides out while he walks into a clinic, that suggests both sensory as well as motor neuropathy. If he's having a foot which is just he's stepping on the floor, that suggests a foot drop. And if he's having ulcer but he's not limping, that suggests he's having severe neuropathy and he continues to walk on that ulcer. And if he's having an antalgic gait, it suggests a neurovascular kind of foot. Another important thing, a simple thing, is you just ask your patient to get up from his chair and walk for 3 meters, turn back and return to the chair. And what you have to do is just note the time of this simple test. Usually a normal person, this simple rising from a chair and coming back takes 10 seconds. But if the patient is having neuropathy and gait impairment, he will take more than 20 seconds. So just by looking at a simple gait balance and performance, you can assess your patients for neuropathy. Now, suppose the patient is on the examination couch, just pay a simple attention to the foot. Look at the nails. If they are dystrophic, like these kind of atrophic and dystrophic nails, suggest neuropathy. If the patient is having these kind of calluses, you can see no ulcers, but calluses there, again just neuropathy. Patient is having a dry and cracked skin, again suggestive of neuropathy. Patient is having clawing of toes. Here you can see the clawing of toes with presence of bunions and muscle wasting or guttering here, that again suggests motor neuropathy, which is a harbinger of foot complications. Never miss the examination of toe webs. Here you can see this is the most common site. Even in our paper that was published in IGMR, we found that around 30% of the foot ulcers begin from this intertriginous area, because this is usually missed. People don't take care of this area, and from here it is connected to the web spaces further, and it leads to very proximal infection. Also look at the nail bed for paronychia and oonychia, because this can lead to further development of ulcers. Another thing that is commonly missed by even my residents is looking at the muscle strength and function, because like we test for maybe the knee flexors and extensors, for foot what is important is again the plantar flexor and the dorsiflexors. Also look at the range of movement, because as you know that in hand we look for chiroarthropathy, that is known as limited joint mobility. We ask for a prayer sign like this. Same thing happens in the foot also. So you have to look for the toe flexion. If it is limited, usually it is more than 15 degrees, but if it is limited, then it suggests that this toe is having limited joint mobility, which can lead to development of ulcers if the patient is wearing rigid shoes. So always assess your patient by looking at a proper history and doing a neurological examination, which should have at least a temperature or a pinprick sensation, because they test for small fiber functions. Always test for a vibration sensation for large fiber function. Annually, at least you should do a monofilament test. You might not go for any kind of electrophysiological test, or referral to a neurologist is very rarely required. Only in certain scenarios, like maybe if you are suspecting maybe AIDP or a CIDP, that is demyelinating polyneuropathy, or if the patient is having severe amyotrophy and you think that it might be some other neurological disorder, you might consider a consultation with a neurologist. But most of the time in a given patient with diabetes and diabetic neuropathy, you should not miss these simple examination tools. And as I mentioned, the most important is a monofilament test, because this has been widely validated. If the patient is not sensing monofilament, which senses the sensation of touch, large nerve fiber function, then this patient is likely to develop a foot ulcer in near future. So this is just during one of my rounds when I was teaching my students. These are the sites where I have made a cross where you have to put your monofilament like this, perpendicular, and then you have to assess for this sensation of touch. Otherwise, if you have facility, this is my diabetic foot lab. If you have a facility, you should do a vibration perception and a temperature sensation by automated neuropathy analyzer. Now, coming on to another thing which we should not miss, I say, during examination, is a simple test which was developed by Dr. Gary Raymond from Southern England. And this was a nice test which do not require any kind of instrument. Even a paraclinical person can also do. You have to just touch the toes of the patient with your fingers and ask whether the patient can sense it or not. If he is not able to sense more than 2 out of 6 areas, then it suggests that this patient is having insensate foot, and he is likely to have a loss of protective sensation and foot ulcer, which is a very good specificity of 90%. And this split test or a touch test is well-validated test. Now, coming on to the second part of my presentation is about never to miss infection in a patient of diabetic foot ulcer. And how will you recognize infection? Just by looking at the classical signs of inflammation like redness, warmth, and swelling, or purulent secretion. But remember, in a given patient with diabetes, there might be certain scenario where the patient might have infected foot ulcer, but it might not have purulence. Like in this scenario, you might have some secondary signs like a friable or discolored granulation tissue, or you can have an undermining of wound edges or a foul odor, which itself suggests that the patient might be having a foot infection. So if you know that you are dealing with a patient of foot ulcer with a foot infection, this is the recent guidelines. Never miss to classify your foot infection by this IDSA and IWGDF guidelines that have been recently updated. And just you need that you can classify your patient into mild, moderate, and severe infection. And you have to add O. O means for osteomyelitis. If after 3 or 4, if the patient is having a bone involvement. So never miss to classify your patients of foot infections. You might have a misdiagnosis if there is no local signs of inflammation. If there is a very small ulcer, throat bone test is negative. You might have a normal ESR, normal CRP, normal inflammatory markers. If you do an X-ray, it might be still normal because it takes some time for the bone changes to appear on X-ray. And MRI can also miss osteitis. So you have to depend on a clinical acumen so that you do not miss a diagnosis of foot infection. Never miss taking proper cultures in your patient if you are dealing a patient of foot ulcers. Ideally, it should be from a deep tissue and obtained by proper cleansing of wound and then obtaining a biopsy or a curettage after thorough debridement. Never take a swab specimens in your patients of foot ulcers. It should be absolutely no. Now, this was a paper that we published in JDC, and this is about the importance of taking cultures. So this is say that if you are dealing with a soft tissue bone infection like osteomyelitis and you just treat your patient by doing a soft tissue cultures, you are likely to have non-identical organs in around 21% times. That means you will treat with an organism which is grown from soft tissue, but unfortunately patient has a bone infection. So 1/5 of the time your patient will never heal of osteomyelitis. Same if you just take a pus culture and you don't take a bone culture in osteomyelitis, 60% of the time you are likely to be wrong. Therefore, always take appropriate culture. If it is suspected bone infection, take the bone for culture. If it is soft tissue infection, take soft tissue cultures. Role of serological markers, yes, there is some role, but it is only adjunctive measure. So never miss and over rely on ESR and CRP for making a diagnosis of infection. Coming on to the imaging, the third part of my presentation, that is also very important. Never miss or shy in doing imaging for patient with diabetic foot infection. And it is recommended that you should do a plain radiograph for almost all suspected cases of diabetic foot infection because you need to rule out bony deformities and abnormalities, presence of foreign bodies, soft tissue gas, and like osteomyelitis. If MRI may be needed if there is suspicion of soft tissue abscess or a deep infection. And sometimes you need to do some kind of nuclear scans also. Never miss doing nuclear scans. And this is just to show some of the X-ray pictures. So this gentleman came with a non-healing ulcer over the heel, you can see. But once we did an X-ray, we found that whole of the calcaneum was showing fractures and it was osteomyelitis. Same here, patient was having a grade 2 ulcer. Once we did an X-ray, we found that patient was having osteomyelitis. So X-ray is important and we should not miss doing that. This is a small thing that we published regarding the use of labeled WBC PET, and this study was quoted in recent IWGDF guidelines also. And what they say that this modality is sometimes useful for diagnosing osteomyelitis in a given patient of complicated foot ulcers. And this modality gives these kind of pictures which suggest that this patient is having osteomyelitis of the head of the first metatarsal. And we found out in this study that this is 100% specific for diagnosing foot osteomyelitis in complicated foot ulcers. Regarding the choice of antibiotics, that is very important for foot ulcers. So never mistreat your patients of foot ulcers with irrational antibiotics. It should be properly obtained from cultures. So in this, this follow-up study, prospective study of 293 patients, we found out that in our institute, the Pseudomonas was the most common organism. And unfortunately, most of the time, if it is Pseudomonas, it's unlikely to respond to quinolones, though it is likely to respond to cephalosporins only 60% of the time. So I need to mention it that you have to judiciously use your antibiotics based upon the cultures. And these are just IWGDF guidelines that I mentioned. If it is a mild infection, it's likely to be treated with a simple clindamycin of first generation cephalosporin because it is likely to be gram-positive cocci. Otherwise, If it is moderate to severe, it's likely to be gram-negative, and you have to choose a third-generation cephalosporin. So do not miss treating with antibiotics with a proper dose, but also duration is also important. For if it is a mild infection, just 1 week of antibiotic is good enough. If it is moderate to severe infection, just 2 weeks of antibiotic is enough. If it is osteomyelitis, around 4 to 6 weeks of antibiotics is needed. Do not ever treat uninfected, clinically uninfected foot ulcers with antibiotics, because antibiotics is for only infection, not for healing of ulcers. Do not apply any kind of topical antiseptics or silver preparations, because they are not backed by guidelines, especially the recent IWGDF guidelines. And do not use any kind of GCCF. It has a very weak evidence. The last part of my presentation, again, a very common missed entity, because my presentation about missing things. So do not miss this diagnosis. So this gentleman, 53-year-old, presented with around 12 weeks of swelling, which is in the right foot. It was diagnosed as cellulitis. He was treated with antibiotics. Somebody also diagnosed osteomyelitis, but nobody got an X-ray. It was Charcot's foot. Once we got an X-ray done, unfortunately, it was suggestive of this picture. So the whole of the midfoot, hindfoot, everything is gone in this patient because this was a misdiagnosed case. We published this as vanishing bone disease in postgraduate medical journal, but I mean to show this pictures because again, another patient, you can very well see the left foot is swollen, red, and it was warm on touch also, as compared to the right foot. This again suggests osteomyelitis. We did a bone scan. You can see markedly increased uptake. So we again published this in IGDDC at varied presentations and outcome of Charcot's. So these Charcot presentations should never be missed in your patient. Strangely, we had another patient who had both foot Charcot as well as wrist Charcot concurrent. This patient had left foot Charcot, you can see red erythematous, same as compared to the right wrist, left wrist was swollen and red. Sometimes you can have surprises. You should not miss looking even at the wrist of the patient because it is a glove and stocking kind of neuropathy. So this is again wrist Charcot's that we published. So never miss the use of these kind of infrared thermometers for taking temperature of the foot because it can tell you about inflammation. It can also tell you about the occurrence of Charcot's in your patient because your hand does not have much sensitivity in recording temperature because it has sensitivity only of 3 to 4 degree Fahrenheit difference. So we need these kind of thermometers. And how to treat. So never miss treating your patient of Charcot's neuropathy. So this was the paper that we published in Diabetes Care. It was the use of methylprednisolone or zoledronic acid in patient with Charcot's. And we showed that total contact cast is the best therapy. So these patients who were in the red bar were on total contact cast, in green bar were on zoledronate, and red bar were on methylprednisolone. So this is the time to resolution, which was all least with simple total contact cast. So overall, I mean to say that a simple contact cast is useful for treatment of Charcot's neuropathy. But yes, if you are dealing a patient of chronic Charcot's foot, you might use teriparatide because we showed in our paper that teriparatide has the potential for increasing the bone mineral density. So we, in a placebo-controlled study, we found out that those patients who are on placebo, foot bone mineral density decreases with the time. This was a study for around 1 year. But if you are using teriparatide, the foot bone mineral density in patients with Charcot's increase, and that is very useful for preventing collapse of the bone and deformities. The patient with Charcot's, do not mistreat, do not miss a diagnosis, and this kind of contact cast is the gold standard for treatment of a patient. And once the temperature resolves, you can shift on to this kind of crow boots. Last part, never miss fungal infections in patients of foot complications. So this lady came just with a small swelling over the midfoot area. We thought that this might be a soft tissue tumor. We went ahead with a biopsy. First we went ahead with an MRI. You can very well see X-ray there was a soft tissue swelling. On MRI also the swelling you can see. Then we did a biopsy and we found out that a lot of fungal hyphae were seen here. You can see the fungal hyphae here. So we again published this as an innocuous foot lump in a lady who just presented with a lump. No problem was there, no pain was there. And it was pheohyphomycosis, again a fungal infection of the foot, which was later on excised and treated with voriconazole. Last part again, this is about the vascular neuroischemic foot ulcers. Never miss the vascularity of the foot. So always palpate pulses, dorsalis pedis and posterior tibial. Always take an ABI of a patient, and please ask your patient to remove shoes and socks. Look at their footwear, because this is the most common cause. Bad footwear is the most common cause of foot ulcers. I've seen these kind of footwear in my patients. These jutis, you can see a nail here popping here, which lead to an ulcer. This does not have an insole, which lead to the foot ulcers. So overall, after learning all these things, you should be able to recognize neuropathy, vasculopathy, and recognize patients who are at risk of developing foot complications, so as that you can prevent amputations in your patient. So I mean to say that do not miss looking at the foot in every patient of diabetes who enters into your clinic. If you look at the foot, then only you can recognize that it is inflammation, infection, or Charcos. So thanks, and back to Dr. Das, sir, please.
Thank you, Ashu, for a wonderful lecture, jammed with a lot of practical, clinical, day-to-day business things. No, I remembered what has been said in Sri Aurobindo once wrote, the greatest things in the world are simplest. And your talk was simplest, but it ran through the renal diabetic foot, upcoming subject. It ran through the renoretinal foot. It also ran through the equivalent of diabetic ischemic foot with coronary disease. You said about that ischemic diabetic foot is equivalent to coronary disease, and that today Government of India has taken up as a male health indicator. The ABI, if it is less than 0.6, whatever, 0.7 is a male health indicator of coronary disease. You did speak about and I like the way you put it, the mortality, 16.5 versus 3.1. That makes everyone jump up on the seat. And you beautifully said, it was from your institute, I remember, from my institute also, the cause of death in diabetes. It was infection. That time, number one. Today, I don't know if new studies have come or not. And you showed that how diabetic foot infection is easy to treat. You told about simple things, monofilament Ipswich touch test. You took it to FDG leveled PET and CT. So I think I like the way you presented it. There are a few questions which have come, which I'll take up. My first question to you is very simple. That is a question from Dr. Ghanshyam. I think Ghanshyam Goel Fay must be. Does vacuum application help DFU? I think I'll a simple request. We have got about 2 minutes, so we come to give a little quick answer, brief answer. Does vacuum application help in DFU? Vacuum application.
Yes, sir. Vacuum application definitely helps in diabetic foot ulcers, specifically if it is a very draining wound, whether it may be exudate or serous fluids, vacuum helps. And it has been recommended by IWGDF also.
Fantastic. The question from Dr. Ravi Kumar wants to know how to take tissue culture in cellulitis, but no ulcer.
Exactly.
You did talk about the biopsy, all that, but cellulitis, no ulcer. How to take a tissue biopsy? Fantastic.
Exactly. So in a given patient who does not have an ulcer and has a cellulitis, the first dictum is never ever create a breach in the skin, because a natural skin is the most important repellent for infections. Most of the time, cellulitis, gram-positive coca is the most prevalent organism. You can just deal with antibiotic which deals with GPCs or gram-positive coca, but never ever try to take culture by breaching the skin in cellulitis without ulcers.
Fantastic answer. Last one question before we pass. I hand over the entire session to Dr. Suresh Prabhu. This is it is said, it was told by Andrew Bolton. You must have heard that for a mistake we do by not knowing it, we make 100 mistakes knowing but not looking. Yes. I think your talk summarizes what we know but don't look into it. I think, Ashu, I must give you a great credit for this. Thank you very, very much. Compile it in a book form for all the practitioners to know, all of us to know. Thank you, Ashu. Thank you very much. Dear friends, for the rest, two phenomenal speakers, one from US and who has done, she has done plenty of work on a very common topic, and our ASICON ESI president. I hand over the entire session to Dr. Suresh Prabhu. Suresh Prabhu, all is yours.
Okay. Thank you, sir. Thank you, Dr. A.K. Das, sir. At the outset, I welcome Dr. Sangeeta Kashyap, who is a professor of medicine at Cleveland Clinic Lerner College of Medicine. And she's also affiliated to case was reserved in university. She had more than 130 publications, particularly in high impact journals like JCM, Diabetes Care, and NEJM. And she's also the NIH NIDDK grant recipient. With this introduction, we proud to have Dr. Kashyap in our Trendo. Welcome, ma'am.
Oh, hello. Can everyone hear me okay?
Yes, ma'am. Yeah.
Wonderful. So I will go ahead and try to share my screen. Just 1 second. Inbox, whiteboard. Just 1 second. Can someone help load my slide deck, please?
Yes, ma'am. So we can play your slides for you, and then you can just guide us next when you want to take the slide, and we
please, if you could. Somehow it's not showing up. Yes, that's it. Okay, so thank you, Dr. Sheshadri. What a wonderful opportunity for me to present this topic. It's a very common topic, but I think we are learning more and more about how to deal with obesity in the patient with type 2 diabetes. Next slide. So I'll start with the case. A 50-year-old woman with PCOS referred for weight management. PCOS was diagnosed at age 15. She gained weight through college and during her first job, which was very sedentary. She had a baby at age 36 years with the assistance of clomiphene, but had difficulty losing weight after delivery. She had lost 18 pounds over the last 6 months by participating in a commercial weight loss program and exercising regularly, but her weight has plateaued. She now has type 2 diabetes, hepatic steatosis, and occasional migraine headaches. Current medications include metformin, which has led to an A1C of 6.5% and a selective serotonin reuptake inhibitor. She also has gallstones, which was noted on an ultrasound done a few months ago, and her current BMI is 33. Next slide. So which of the following should be recommended for continued weight loss? The choices are naltrexone bupropion, liraglutide 3 milligrams daily, phentermine topiramate, and semaglutide. So I will go ahead and show you the answer. Go ahead, next slide, please. So the answer is phentermine topiramate, and the reason is because this is one of the most effective oral agents we have for weight loss, and in this patient with gallstones, there is concern for using GLP agonists. Okay, next slide, and we'll discuss more about these options. So again, my learning objectives are to review the appetite system, drug pathways, talk about new pharmaceutical approaches to weight loss and their targets, and also discuss the clinical efficacy and side effect profile of bariatric or metabolic surgery. Next slide. So obesity is very complex and multifactorial. I think we need to recognize that genetic and epigenetic influences account for 70% of obesity. The remaining is acquired, and we can distribute that in terms of increased caloric intake, biological influences of hormone, leptin resistance, adiponectin deficiency, etc. There's also large influence by gut microbes, an imbalance of signals related to energy regulation, that is, signals from the gut and adipose tissue that are processed in the hypothalamus. Next slide. But weight management in the clinical setting is very challenging, as most of you know, because there are many factors that are sometimes out of our control. So the job of the clinician is really to focus on things that we can address during the office visit and to be proactive about these issues. Next slide. So, what are some of the metabolic benefits of progressive weight loss? Well, very elegant studies have been published and have shown that even modest 3 to 5% weight loss improves multi-organ insulin sensitivity and beta cell function. Additional weight loss of 11 to 16% further increases insulin sensitivity in the muscle. And beyond this, with diet and exercise, progressive weight loss can cause a stepwise change in adipose tissue biology. So we can see the whole adipose tissue, the inflammatory profile is changed with stepwise approach to weight loss. And this is very, very important for us to achieve. Next slide. So the classic study, I think, in terms of weight loss for type 2 diabetes is the Look Ahead study, which was an intensive lifestyle intervention trial. And these data are changes. So the patients who were enrolled in Look Ahead, their ages were 45 to 76. They had type 2 diabetes. BMI was greater than 25. They were placed on a 12 to 1800 calorie diet. They were counseled for 175 minutes a week of activity. They had support sessions, meal replacements with protein shakes were supplemented. They were closely monitored as opposed to the control group, which had some counseling at the beginning of the study and less frequent follow-up. And you can see these are the weight changes at year 8, and you can see the percentage of participants. So it's interesting. Some patients lost between 0 to 5%, some patients lost 5 to 10, some patients even lost greater than 10%. But despite all these efforts, if you look in the lifestyle group, almost 25% of patients gained weight in the Look Ahead study. Next slide. And if we look at the 10-year trajectory of clinical parameters, you see that the best effects were at the first year for the intensive group, where they lost almost 8 kilos in the first year. But over the course of subsequent years, there was weight regain. This was a parallel observation when we looked at waist circumference, physical fitness, and physical fitness again. And what we see is that initially there was a boost that you see, and then over time there was attenuation of these effects. Next slide. So this is very frustrating for clinicians. It's very frustrating for patients. Why do we experience weight regain after such intensive efforts and so many resources that are, given to patients? Well, that's because of metabolic adaptations to a reduced body weight. So what we see is that when a patient loses weight, there is a reduction in body mass, a reduction in energy expenditure, there's an increase in hunger hormones, and there is an energy gap. There's other hormones that are also affected. So increases in ghrelin, decreases in PYY, in CCK, GLP, insulin, leptin. So the balance of the hormones create this sensation of hunger and reduced satiety. And because of this, we see commonly there is weight regain after weight loss. Next slide. However, even though the results from Look Ahead were somewhat discouraging in terms of the weight regain, what we still saw long-term from this study, there was improvement in blood sugar and lipid control, improved blood pressure, less sleep apnea, improved hepatic steatosis, less depression, less urinary incontinence, less severe kidney disease. There was greater physical mobility, less knee pain, improved sexual function, lowered inflammation, and reduced healthcare cost. So intensive lifestyle and addressing weight loss through intensive lifestyle is very important for us to do. Next slide. However, the look-ahead trial, the conclusion of this randomized controlled trial was that these intensive lifestyle efforts did not reduce the rate of cardiovascular events in overweight or obese adults with diabetes. And one of the interpretations of this conclusion is that perhaps greater and longer sustained weight loss is necessary to produce a clinical benefit, especially for cardiovascular disease. Next slide. So let's talk about long-term weight loss in the DPP study. So we all know the DPP study initially was 2.8 years of follow-up. There was an intensive lifestyle group that lost about 5.5 kilos. The metformin group lost about 2 kilos, and the placebo group was essentially neutral. But what they found was that weight loss was the primary driver for diabetes prevention. Now, over the course of 10 to 15 years of follow-up, notably the DPP-OS follow-up cohort, the intensive lifestyle group regained 3.5 kilos and had a net weight loss of 2 kilos at 10 years. The metformin group actually maintained 2 kilos weight loss, and the placebo group was neutral. Next slide. And we can appreciate this really in this slide. And I think the clinical message, the take-home message, is that intensive lifestyle therapy was the most effective for diabetes prevention. However, when you look at long-term weight loss, the addition of metformin led to sustained weight loss. And you can see that the percent change in weight loss in the metformin group at 10 to 15 years was far greater than just the intensive lifestyle group. So metformin, I think, is a very useful adjunct for maintaining long-term weight loss in patients with prediabetes. Next slide, please. And the predictors of weight loss, long-term weight loss, who lost the most weight at 15 years? Well, patients who lost the most amount of weight at the first year were more likely to maintain that weight loss over 15 years. There were other predictors as well, but the most important thing was the weight loss at the first year. Next slide. So how do we harmonize treatment goals with the patient? So this slide, shows you that we have to compromise. So we recognize that a patient has an ideal body weight that they may want to target, but at the same time, as an endocrinologist, we know that even minor, modest weight loss will result in improvement of health. And that is what we're really targeting. We want to prevent and treat complications of obesity, prediabetes, metabolic syndrome, hypertension, dyslipidemia, elevated liver transaminases. And really, the approach should be trying to balance, what is the ideal body weight and improvement of overall health status with minor or modest weight loss with diet, exercise, and anti-obesity pharmacotherapy. Next slide, please. This slide really summarizes some of the medical complications of obesity. And we know that through the look-ahead study and other trials, that even minor weight loss can have significant improvements in all of these complications of obesity for a patient with diabetes. Next slide. So one of the culprits for weight gain are drugs. Many drugs that we use actually can cause weight gain. Notoriously, in patients with diabetes, the use of insulin, the use of sulfonylureas, metigloinides, TZDs are associated with weight gain. So now we use alternatives. We typically add GLP receptor agonists along with basal insulin to minimize weight gain. We use SGLT2 inhibitors. We use amylin analogs along with insulin to prevent the weight that we see increasing with insulin. Beta blockers. Some beta blockers are notorious also for weight gain. Propranolol is a big one, and which I want you to remember. Antidepressants are very commonly associated with weight gain. The big ones are the tricyclics, so amitriptyline, nortriptyline. SSRIs as well are also, paroxetine is a very harmful agent for weight gain. So it's important to look for alternatives, and I've listed the alternatives here. And there are other glucocorticoids, antihistamines are all associated with weight gain. So when I evaluate a patient with abnormal weight gain, I look at their drug list and I try to identify agents that cause weight gain and look for alternatives. Next slide. So these are the recent guidelines produced by the ACE, American Association of Clinical Endocrinology, for the management of patients with obesity. The critical elements of this algorithm is number one, diagnosis. It's surprising how few clinicians actually document a body mass index. But anthropometric measures, clinical measures are very important. Then the second step is staging, and the staging refers to presence and severity of complications. And the last is creating phases of treatment. So multimodality and intensification of treatments based on the disease stage. And then follow-up is very, very important for patients in any weight management program. Next slide, please. So we typically endorse a checklist for patients with obesity so that we can create a list of weight-related complications. And so these are included for you to see: prediabetes, metabolic syndrome, diabetes, dyslipidemia, cardiovascular disease, NAFLD, PCOS, infertility, male hypogonadism, obstructive sleep apnea, asthma, osteoarthritis, urinary stress incontinence, GERD, as well as depression. So documenting the complications associated with obesity is very important. And I think this is how in our society we can justify the use of anti-obesity agents as well as referral to bariatric surgery if patients are refractory. Next slide, please. So the currently available options, well, we have diet exercise, which, as you can see from the Look Ahead trial, it can be effective, results in 3 to 10% of weight loss. Anti-obesity drugs leads to about 5 to 12% weight loss. And then when you use a combination approach of diet plus drug, that can lead to 10 to 15% weight loss, and surgery can lead to 15 to 30% weight loss. Next slide. So here are some of the approved obesity pharmacotherapies and their mode of action. So phentermine, orlistat is used very commonly. They're very affordable too. Phentermine is a sympathomimetic agent. It was approved in 1959. Orlistat is a GI lipase inhibitor and can be very effective when used with a very low-fat diet. And then other FDA-approved drugs include phentermine topiramate, which is a combination of a sympathomimetic with an anticonvulsant. We believe there's some GABA receptor modulation, but it's the most effective oral agent for weight loss. Unfortunately, lorcaserin was taken off the market due to cardiac side effects, but naltrexone bupropion was approved in 2014, is commonly known as Contrave. It's a dopamine noradrenaline reuptake inhibitor combined with the opioid receptor antagonist. And lastly, liraglutide at a high doses is also available and very effective, but very expensive and does involve a daily injection. But I will tell you, in my practice, I typically use a combination of drugs. So I would try to combine drugs like metformin with phentermine, or I also use sometimes bupropion by itself in patients who have emotional or stress eating disorders. And I also combine generic medications such as naltrexone prescribed separately and bupropion prescribed separately. And this approach does work for patients who are not able to afford name brand preparations. Next slide, please. Here's the data with topiramate, phentermine topiramate as compared to placebo, and these are the two doses. And this was a 56-week trial, and you can see compared to baseline, you can see 12 to 14% total body weight loss over the course of 6 to 12 months. And this drug is fairly safe to be used chronically, and I have patients who've been on this preparation for over 3 years now. Next slide. Yes, thank you. But, you know, one of the issues is the risk of birth defects, especially in women who, you know, so women need to use contraception. They need to have, be monitored for pregnancy because topiramate can result in cleft palate of the fetus. Next slide. Next, please. It reduces blood pressure, glucose, insulin, triglyceride, and it also has been shown to raise HDL levels. Next. Caution should be used in patients with uncontrolled hypertension, glaucoma, substance abuse, but this drug can also, because it has topiramate, can help patients who have migraine headaches. Next slide. But it is the most effective weight loss drug we have, and it results in approximately 10 to 12% total body weight loss. Next slide. So this slide really reviews some of the signals that are involved in food intake. So what's important for us to understand is that there are peripheral signals that are generated from the abdominal organs, so the GI tract, the liver, adipose tissue, adrenal glands. All of these signals are incorporated in the hypothalamus, and they can either stimulate feeding or inhibit feeding. And so many of the drugs that are being developed for management of appetite involve regulation of these central systems. Next slide. Let's now talk about bariatric or metabolic surgery. So there are several approaches we have available. Lap band, next slide. Sleeve gastrectomy, which in the US has become the most frequent operation, and gastric bypass, shown here. Next. And you can see the weight loss can go from anywhere between 15% all the way to 25 to 30% with gastric bypass. Next. But there's also greater risk involved with gastric bypass. Next slide, please. So if we compare these operations, what we see is that, and please proceed with next, click twice, please. The lap band is associated with 20% weight loss, very low mortality. It's reversible, but there are some complications with slippage of the bands, which occurs in about 2% of patients. Sleeve gastrectomy is a very good option. 25% weight loss, 0.1% 30-day mortality, 2.4% serious, or 6% any complication. And next, please. Gastric bypass is associated with 30% weight loss, 0.2% mortality, 2.5% any serious, or 10% any complication. Next slide. So systematic review and meta-analysis of these procedures are shown here. And essentially, these procedures, when performed in high volume centers, can be very effective. There's many of the comorbidities associated with obesity and diabetes are improved for patients. And many patients can be independent of insulin, especially for patients with diabetes. Next slide. So this next slide shows basically the benefits of bariatric surgery in a control cohort analysis. So the Swedish obesity study, which was a very large non-randomized study of almost 2,000 patients who had bariatric surgery compared to contemporarily matched control subjects who did not have surgery. It began in 1987. Next slide. And the follow-up was almost 15 years. Next. And this graph shows you the mean weight change from baseline at in the 3 different arms. So in this study, basically they performed gastric bypass and vertical banded gastroplasty, which is really not done in the US, but the data is shown. And you can see that, you know, at a year, there is significant weight loss, 30 to 35%. And at about 6 years, 34%, there was 34% weight regain in the gastric bypass group, but even if you look out 15 to 20 years, you can see significant differences between the placebo group. Next slide. And then when you look at mortality benefits, bariatric surgery does save lives in patients with morbid obesity. So there was a 25% reduction in mortality of surgery versus the control group. Next slide. And a lot of the reduction in mortality was related to reduction in MIs and reduction in cancer-related deaths. So we have to understand that patients with obesity, there's a very high rate of uterine cancer in women, gastrointestinal cancers, a variety of cancers that we're seeing more and more of. Next slide, please. And then let me talk about our own randomized trial where we looked at intensive lifestyle therapy versus bariatric surgery for patients with type 2 diabetes. So this was called a Stampede trial. It was done at Cleveland Clinic, a uni-center study, 150 patients randomized to intensive medical therapy, very similar to the Look Ahead trial, versus gastric bypass or sleeve gastrectomy for the management of type 2 diabetes. The average baseline A1C for our patients was about 9%. And our primary outcome, we were looking at how many patients can achieve an A1C of 6% with or without the use of anti-diabetic medication. The average BMI for our patients was about 36. Next slide. And these patients were followed for 5 years. So I am going to show you the primary endpoint at 5 years. So the A1C of 6%, which was our primary endpoint, was achieved in 5% of the medical treated group, 29% of gastric bypass, and 23% in the sleeve gastrectomy group. Now, what about patients who did not require any anti-diabetic medication? So 22% in the gastric bypass group did not require any insulin or oral agents, and 15% in the sleeve gastrectomy group. Obviously, in medical group, it was 0%. But you can see from these parameters, there was vast improvements in HDL, tremendous reductions in triglycerides over and above the use of statins. Next slide. We also reported the percent reduction in the use of need or requirement for insulin. And so over 90% of patients after 6 months did not require insulin in the gastric bypass or the sleeve gastrectomy group as compared to the medical group who initially, after the first year, because we incorporated GLP agonists, there was a reduction in insulin requirement. However, over the course of 3 to 5 years, there was an increase in the requirement of insulin. Next slide. So there are many. How does gastric bypass, how does it improve diabetes? Well, you know, obviously many of...
Dr.
Yes.
Kashyap, sorry to interrupt the time. I think you should fix it.
Certainly. So let me just finish by saying that these are some of the weight independent mechanisms that are shown here. We are still learning about how bariatric surgery helps. Next slide, please. I'm going to skip to my last slide, please, which will be the conclusions, and then we'll save a few minutes for conclusions. Next slide, please. So these slides are available for you all to review on your own. And but these are my conclusions. Management of obesity in patient with diabetes improves comorbidities and quality of life. Due to metabolic adaptations, weight loss is associated with weight regain, and a multimodal approach for weight loss with diet, exercise, pharmacotherapy, and metabolic surgery are our options. Thank you.
Thank you, Dr. Kashyap. That was an excellent talk regarding the obesity. I think we have our plenary session at 9 o'clock, so I think we are short of time. So probably the questions, I think they may put it in the chat box. We can discuss in that one. So we'll be moving on to our next session. Thank you, Dr. Kashyap.
Thank you.
Thank you. Yeah, so I'm privileged to introduce the next speaker, Dr. Ganpati Bantwal. He's head of the Department of St. John's Medical College, Bangalore. And he's president of Endocrine Society of India. He has more than 85 publications in peer-reviewed journals. And he is a member of the Endocrine Society and RSSDI, and has many credit to his name. So with this introduction, I invite Dr. Ganpati Bantwal. Sir, it is a privilege to have you here. Thank you for accepting. So we can move on. And the topic he'll be going to discuss is about the cardio-renal metabolic risk reduction with SGLT inhibitor. What is the evidence we have, and how do we practice? Welcome, sir.
Thank you, Dr. Suresh Prabhu. Let me thank the organizers, Dr. Vijay in particular, for inviting me to speak on this topic. As you know, SGLT2 are the molecules of the decade. I always think that this is a catabolic drug because you're losing weight, you're passing out glucose in the urine. So I thought it really doesn't make sense. But then this has actually changed the scenario how we are managing diabetes. Initially, it came as a drug which can reduce glucose levels. And then we found that it's not only that, it is cardiovascular safe, it is renal safe, it's very useful for heart failure. So you can say this is the molecule of the decade. So as you know, type 2 diabetes is multifaceted disease comprising cardiovascular, metabolic, and renal complications. So the metabolic in the form of hyperlipidemia, non-alcoholic fatty liver disease, obesity, cardiovascular, hypertension, coronary heart disease, heart failure, acute coronary syndrome, and CKD, renal in the form of chronic kidney disease and hyperkalemia. So the prevalence of the CVD has been declining over the past few decades, but then now it seems to be on the rise once again. This is one of the studies which came in diabetes care last year. This is a diabetes of aging population. It's a cohort from California who are followed up for more than around 12, 13 years. So what you can see here, all the complications increase when you have an HbA1c, say from 6.5 to 7, 7 to 7.9, 8 to 8.9, more than 9. So the more the A1c, especially in the first year, if you don't have that control, you find that microvascular complications increase, macro increase, and also the mortality. So among patients with newly diagnosed diabetes, in 10 years of survival, A1c levels more than 6.5% of the first year after diagnosis were associated with worse outcomes. Immediate and intensive treatment for newly diagnosed patients may be necessary to avoid irremediable long-term risk of diabetic complications and mortality. But then we have had trials of intensive glucose lowering. They showed little macrovascular benefit, the UKPDS. So you got the benefit only during the follow-up part when you found that there was a reduction in mortality and also there was a reduction in the CVT. ECHO trial had to be stopped because the mortality increased. ADVANCE was neutral. The VADT was also neutral. So we did not find any benefits for the intensive glycemic control. So coming to the diabetes, it's interrelated. So you have a diabetic kidney disease, heart failure, they're all interrelated. So it's a vicious cycle actually. So type 2 diabetes leading on to heart failure leads to low cardiac output, increase renal venous pressure, activates the sympathetic nervous system and the RAS, constricts the afferent arteriole, leads to decreased glomerular filtration, CKD. So you have secondary hypertension and anemia, which in turn can worsen the heart failure. Heart failure, once again, you have an increased sympathetic nervous system activity, means you have increased insulin resistance, and you find that the diabetes can actually worsen. So the risk of cardiovascular complications, as you know, are much greater in diabetics versus that of the general population. Whether you take peripheral arterial disease, non-fatal MI, or stable angina. This is from the UK Caliber program, which examined approximately 18 lakhs patients, control patients, and 35,000 patients with type 2 diabetes to assess the most common initial manifestation of CVD. So you take anything, there were more in patients with diabetes. Diabetes is also the most important determinant of development of heart failure. You can see here, compared with even smoking, LDL, hypertension, or obesity. And the burden of heart failure also has been increasing over the recent years, and improvements in related mortality have been modest. So you can see that the number of new heart failure diagnoses has been increased by around 12%. Number of people living with heart failure has increased by 23%. Survival also is actually stable, or you can see it's less, you can say. So the type 2 diabetes is a major risk factor for development of renal disease also. So you can see on the left-hand side patients with diabetes versus no diabetes. So roughly a threefold increase, you can see. And heart failure is the most common CV complications in diabetic kidney studies, which drives the cardio-renal interplay in type 2 diabetes. So you can see in the renal, that was the highest incidence was of heart failure, the same thing in the IDNT, and the same thing in the altitude study. You can also see that risk of heart failure, CV death correlates with the declining renal function. If you have microalbuminuria with a reduced ejection fraction, heart failure, they have the worst outcome. The cumulative incidence of heart failure is highest there, compared with no microalbuminuria and heart failure with preserved ejection fraction. So you can say almost a tripling of the incidences of heart failure happens. Similarly, the CV death according to the yearly eGFR change. So when you have a GFR change in the eGFR slope more than 5 ml per minute per 1.73 meters square body surface area, the survival actually comes down significantly compared to those who have had a eGFR slope less than -5. Heart failure also, as I told you before, increases the risk of renal function decline and of adverse renal outcome. So you can see with heart failure, rapid eGFR decline is around 22% compared to those without heart failure, which is around 9%. And heart failure is also associated significantly with incident CKD and incident CKD or mortality. So persons with heart failure have a higher incidence of these complications. But you must also remember that this cardio-renal risk development runs along a risk of continuum, highlighting the importance of early prevention. So even before the diagnosis of diabetes, avoid smoking, if you're obese, lose weight, control hypertension, control dyslipidemia. Now, once you have developed diabetes and the diabetes progresses, then you start developing the complications like heart failure, CKD, ASCVD. Then you get an event, which could be a cardiorenal or atherothrombotic. Complications, which is a repeated hospitalization for heart failure, progressive renal functional decline post-MI. So you can begin with lifestyle modification, diet, exercise, smoking cessation, but then we require to start medications which target these specific conditions, complications, and outcomes. So there's a pressing need for agents that minimize cardiorenal risk early in type 2 diabetes in order to improve long-term clinical outcomes and reduce the cardiorenal burden in type 2 diabetic patients. So you must be knowing about the Trendo 2 trial involving just 80 patients in each arm, a great study with maybe more than 15, 20 articles in the New England Journal. So even it was a holistic approach, multifactorial control aggressively, hypertension, dyslipidemia, stop smoking, exercise, A1C, say less than 6.5%. So when you did that, you find that you are getting an additional benefit of around 7.8 years of life. All the complications reduced, you can say, by around 50% compared with the conventional treatment, but still the residual risk remains. At the time, there were no glyphosins. Now, will therapy with glyphosin change the outcomes? So if you see the 3-point MACE, if you take a pool from the EMPA-REG, the empagliflozin, the canagliflozin, the dapagliflozin, and also the Vertiz and the CV altogliflozin and the Credence trial. So there is a 10% decrease in the time to first MACE. What about time to first MACE by subgroup analysis by ASCVD? So whether you have ASCVD or not, you still get a benefit of around 11% with these drugs. So when you didn't have an ASCVD, with no ASCVD, it was neutral. There was a trend towards 6% trend towards decrease, but then it has crossed the unity, mark of unity. So what about time to CV death? So CV death also overall, if you take these 5 trials, a 15% decrease in time to CV death. What about time to first hospitalization for heart failure? A significant, so you can say this is the #1 drug for reducing time to first hospitalization for heart failure, a 32% reduction. So all the glyphosins, irrespective of the class, they actually help in reducing the hospitalization for heart failure. And you can see this benefit as early as the 17th day also. Now coming to the renal outcomes, the time to first renal composite outcomes, if we take, they are quite significant, a 38% decrease in the risk of the time to the first renal outcomes. Now you can see here, except for Vertiz, where there was also a trend towards that, all others showed significant benefits in the time to first renal composite outcomes. Coming to side effects of profile of this, except in the canvas and the canvas, though there was a slight increase in the amputations, other studies have proved that it does not. It is, you can say it's neutral. There is no increased incidence. And the Credence trial also added further to that, telling that amputation risk is not there. And what about fractures, which was also seen have been not significant? DKA, yes, of course, there could be a slight increase. You have to be a little bit cautious in this type. So to summarize the effects of glyphosins, the meta-analysis, which represent the totality of CV and renal outcomes data for the 4 SGLT2 inhibitors. So you can see here the greatest magnitude of benefit is for reduction in risk for hospitalization for heart failure and kidney disease progression. It does have benefits on effect on hospitalization for heart failure risk were the most consistent. And hence this, they say to prioritize the use of SGLT2 inhibitors independent of glucose control consideration in patients with type 2 diabetes with or at high risk for CV and renal complications. After this, we have had 2 studies where the DAPA-CKD patient, here dapagliflozin was used in patients with chronic kidney disease. And you can find here the primary composite endpoint of more than 50% eGFR decline, end-stage kidney disease, renal or CV deaths were reduced by around 39%. And the secondary composite outcome of more than 50% eGFR decline, end-stage kidney disease or renal death reduced by 44%. Composite of CV death or hospitalization for heart failure reduced by 29%. And the all-cause mortality also reduced by around 31%. And then we had the Emperor Preserve trial, so where they used empagliflozin versus placebo. So here also you can see SGLT2 inhibition with empagliflozin is effective in heart failure with a reduced ejection fraction with or without diabetes. A 25% reduction in the primary endpoint of composite of cardiovascular death or heart failure hospitalization. The first secondary endpoint, there was a 30% risk reduction of first and recurrent heart failure hospitalization, and a 50% decrease in renal events, which was a second secondary endpoint, slope of decline in glomerular filtration over time. We saw these events in randomized control trial. What about in real world evidence? Do we have evidence for that? Yes, so you can see from the CVD real. So the total events of heart failure in patients initiated on SGLT2 inhibitors versus other glucose lowering drug. So a real world data from 5 countries and more than 3 lakh patients, the CVD real. So here also you can see the all-cause death reduced by 51%, hospitalization for heart failure reduced by 39%, all-cause death or heart failure, the hospitalization reduced by 46%. So this is for SGLT2 inhibitors versus other glucose-lowering agents. If you see the MACE and all-cause mortality for DAPA versus DPP4 inhibitors, once again reduced, MACE reduced by 21%, all-cause death by around 41%. Then you had the CVD Real 2, where they compared SGLT2 inhibitors versus other oral glucose-lowering agents. 19% reduction in MI, all-cause death by 49%, 36% reduction in hospitalization for heart failure, and 32% reduction for stroke. So you can see overall they have a beneficial effects on the cardiometabolic renal effect. The glucose lowering effect is specific for the diabetic kidney disease. A reduction in weight affects all of them. Lowering of blood pressure, it can reduce the systolic by around 5 millimeters. So that helps for the heart failure, atherosclerosis, and DKD. Natriuretic effect for heart failure and diabetic kidney disease. Anti-inflammatory for all. Antifibrotic for kidney disease and heart failure. Reduction in extracellular matrix turnover. Amelioration of intrarenal hypoxia. Restoration of the tubular glomerular feedback, especially for diabetic kidney disease. Reduction in natriuretic peptides for, once again, the heart failure and the DKD. Reduction in energy demand. Reduction in liver fat. So overall, how does it bring about this? So sodium glucose transporter reduce the oxidative stress, decrease fibrosis induction, decrease the local inflammation, decrease tubular senescence, decrease glomerular damage. So, and also possibly a direct renal protection effect. It can, via its natriuretic effect, reduce blood pressure, amelioration of volume overload, reduces the intraglomerular pressure via its effect on the tubular glomerular feedback, which leads to renal protection. Via its glucosuria, leads to glucose control, weight loss. Overall, it can lead to cardiovascular protection. And for the cardiovascular and renal protection, reduction in glucotoxicity, plasma volume, improvement in hematocrit and hemoglobin, reduction in the arterial stiffness and blood pressure, and improved cardiac fuel bioenergetics because of its usage of the superfuel, the ketones, increase weight loss, decrease in adiposity, decrease in inflammation. Via this cardiovascular and renal protection, you get it. And because of these, the guidelines also have changed from 2016. So till 2015, we were using this drug only as a glucose lowering agent. From 2016, we added for CV and mortality benefit also. And in 2018, the benefits in ACVD and chronic heart failure was added. In 2019, nephroprotection in type 2 diabetic with CKD with diabetic kidney disease. And in 2020, you can see here, if you find that after metformin, if the patient has high risk of or established ASCVD or CKD or heart failure, if ASCVD, if heart failure or CKD predominates, use SGLT2 first, then you can use the GLP-1 agonist. If ASCVD predominates, first preference to GLP. If you are not using it, then use this SGLT2 as a next. The European Society of Cardiology went one step ahead. They told you can use this drug even in drug-naive patients if they already have a ASCVD or high or very high risk CV risk, that is target organ damage or multiple risk factors. Use this drug as a first line And only when you don't have it, use metformin. So they went one step ahead. Now, next question comes, yes, we have this. Are they cost effective? So if you see the annual cost per affected patient per year for cardiac events, you can see it's around $53,269 for hospitalization for heart failure. And for CHF, it's around $30,967. So it's a very expensive thing. When you have a cardiac event, it's very expensive. Similarly, renal, my professor used to say, kidney disease should never come to a poor man because he can't afford it. So if you see, using this, will it actually help it? Yes, you can see total cost of using the glyphosins. Your inpatient cost is actually reduced by around $638, outpatient by $730, pharmacy cost, there could be an increase, but then overall reduction. Health resource utilization, hospitalization reduced by 22%, length of stay decreased, emergency department visit decreased by 20%. So overall, this is for the empagliflozin. For canagliflozin, total cost saving is around $2,000. So end-stage renal disease or renal death, $1,000 reduction. Hospitalization for heart failure, $526. ACVD events reduced by $628. But then, in spite of all this evidence, there's a clinical inertia. So which could be because of, I don't have so much personal experience, so I don't use it. Competing priorities, limited knowledge of evidence from CVOTs and the role of cardiorenal risk, lack of interdisciplinary care and exchange between specialties, and insufficient opportunity for treatment re-evaluation. So you can see here, one is the Optum claim database. The DPP-4 continue to be in the top, though there is an increase in the usage of SGLT2 and the GLP-1. It's just around 8%. So similarly, you can see various records. The DPP-4 continues to be in the top. So there has been, you can see in another study where they found that many are using GLP-1 for hospitalization for heart failure, where the number one drug is actually SGLT2. So in these nations, it's not the cost which matters, actually lack of knowledge, you can say. So overall, though there is an increase, it is not reached to the levels what we want. So we require to defeat this clinical inertia. So we should be advocate for post-CVOT treatment pathways that separate A1C targets from cardiorenal protection. Be a voice for local guidelines that are ambitious for patients and regularly updated. Collaborate on local education initiatives. Deliver interdisciplinary care. Educate reimbursement authorities. Facilitate patient empowerment while helping patients understand the goals of cardiorenal protection. Gauge the individual physician performance to provide feedback and incentivize change. So at each risk, evaluate whether the patient has ACVD. If he has it, switch to an SGLT2. If he has heart failure, especially an ejection fraction less than 45%, add on or switch to SGLT2 with proven benefit. CKD EGFR between 30 to 60 or urinary albumin creatinine ratio more than 30, add an SGLT2 inhibitors. So to conclude, type 2 diabetes is a progressive disorder with development of both microvascular and macrovascular complications which develop with time. SGLT2 inhibitors have shown to possess a favorable metabolic profile and to significantly reduce atherosclerotic events, hospitalization for heart failure, CV, and total mortality and progression on CKD. Their use is now being studied in the treatment of heart failure and chronic kidney disease, even in patients without diabetes. All the guidelines have incorporated it for the treatment of diabetes with ACVD, heart failure, CKD, with EGFR more than 30. Unfortunately, there's a clinical inertia for its use, the barrier of which is required to be broken, which is possible with better patient and physician education, which could result in reduced morbidity and mortality. Thank you for patient here.
Thank you, Dr. Ganpati Bandwal. That was an excellent talk regarding overview regarding the SGLT2 inhibitors. For want of time, I think I'll just ask one question. After metformin in a patient, this is a question we actually raised several times. When the patient doesn't have an increased risk of cardiovascular disease, what will be your choice of, this is a natural patient, what will be choice second line drug after metformin?
So actually now if you see the evidences, because now it is said to even prevent heart failure, even in patients with multiple risk factors, I think SGLT2 inhibitor should be the number 2 drug. But then in a busy OPD, it becomes sometimes difficult because you'll have to tell, okay, you will lose weight, you'll pass more urine, you may get fungal infections. So many times what happens, we don't have the time and we end up writing a DPP-4 inhibitors because you don't have to tell anything, just prescribe them.